All right. Just want to let everybody know I have no disclosures today. So for those who don't know me, I think everybody knows me here. My name's David Chang. I'm one of the chiefs this year. Today I'll be talking about the application of biomaterials in otolaryngology. My goal here, hope today, is to provide you with an overview of the field of biomaterials and clinical applications in otolaryngology. This is a pretty exciting topic for me, and hopefully you all get something good out of it. So I wanted to start this talk with a video to illustrate how biomaterials might be used in the future in otolaryngology. Oh, there's no sound. So, we're obviously not to this point yet, but I feel like the field of biomaterials has made significant progress. Okay. So today I plan on talking to you about the rationale for the use of biomaterials, the history, the development of biomaterials over the years, current applications in otolaryngology, new developments, and then finally future considerations for the use of biomaterials. So first of all, why biomaterials? We've long had a need for options to replace and restore function and anatomy. Loss of function and anatomy can occur with sequelae of disease such as infections, malignancies. There's a loss of anatomy with surgical resections such as mandibulectomies for cancer, trauma, traumatic injuries, as well as congenital defects such as microtia. So autologous tissue is basically the gold standard. It's the primary option for most of the situations where we're replacing tissue. We try to replace like tissue with like. This includes replacing skin grafts, or using rib grafts as a replacement tissue, free flaps, fibula free flaps, for instance. Unfortunately, this option suffers from limited supply as well as donor site morbidity, such as wound infections and wound dehiscences. So biomaterials provide an option to address this limitation. Biomaterials are any material really that either synthetic or natural that are utilized in the body and have a biological interface. They can deliver things like steroids, growth factors. They can be used to facilitate cell attachment in the body. They can be used to guide the growth of new tissue, such as conduits for nerve regeneration. They can provide rigidity or flexibility depending on the application. They can also provide construct structure depending on what you are trying to build. So the field of tissue engineering developed as a way to provide options to replace tissues. Biomaterials play an integral role in this field. The schematic here shows how biomaterials are involved in this process. Basically, the engineered tissue, the engineered tissue is a combination of cells, bioactive factors, as well as biomaterials, or any combination of the three. And biomaterials are in the blue circle here, providing scaffolding material, synthetic or natural, as I mentioned. They can help deliver bioactive factors, and then they can provide structural support and direct cell behavior. So how did we get to this point with biomaterials? Well, sutures were probably the first noted biomaterials. There's evidence to show that they were used some 30,000 years ago. Different materials that were used include hair, bark, metals. There's gold wire ligatures in about 130 to 200 AD. 600 ADs, the Mayans use seashells for nacre teeth and achieved great bone integration. In 1508, Leonardo da Vinci came up with the concept of the contact lens. In terms of biomaterials in the post-World War II era or time frame, materials that were used for planes, for automobiles, were tried in medical application. These include plastics such as silicones, polyurethanes, Teflon, nylon, and metals like stainless steel and titanium. And you can see that some of these materials we still use today. 1960s was really where the biomaterials field took off. This is where there was development of specific biomaterials for biomedical application. For instance, hydrogels were formed from polymerization of polymers, leading to development of the soft contact lens. Hydroxyapatite was used, and first reports were shown in 1969. Polylactic glycolic acid, which we use today, was shown to be degradable in animals in 1966. In 1960s, we also saw the development of bioglass, which is a completely synthetic material that's used with osseointegrative properties. So the field of biomaterials progressed as we began to consider not just materials, but also biological interactions. So we realized that cell biomaterial interactions were extremely important, and these were emphasized in research. There is significant, now extensive evidence in the literature for material surface properties influencing the behavior of cells. Material surface properties include topography, charge, hydrophobicity. All of these can influence proliferation, cytokine production, as well as cellular adhesion. The schematic here shows how we might be able to tailor biomaterials to guide cellular behavior. It's a little unclear, but the implant surface, the implant can be made with different polymers, metals, ceramics. They can be biodegradable or not. They can have different topography. You can add coatings such as to elute steroids. Chemically modified surfaces can provide hydrophobicity, charge, can provide adhesion molecules for cellular interactions. So initially, the thought for biomaterials was really we need to find biomaterials that are compatible in the body. Once we implant it, the body basically doesn't see the biomaterial and won't reject it. But now biomaterials are seen in a much bigger role, hoping to be an active player in tissue engineered constructs. So they can be used to, as I said, deliver drugs, to deliver growth hormones, deliver cytokines, and they can also be used to show certain bioactive moieties for the cells. And so the goal is really to mimic the native environment. Common biomaterials that have been used, I already mentioned hydroxyapatite, which are in ceramics, titanium for metals, synthetic polymers like polylactic acid, polyglycolic acid, polylactic glycolic acid. These are all biodegradable synthetic polymers. Natural polymers like collagen and alginate. And these can be formed into hydrogels, as I'll mention later. So our field of otolaryngology makes use of a lot of these common materials. In laryngology, Dr. Damrose uses a silicone block that he carves for his medialization thyroplasties. Dr. Sung uses Gore-Tex PTFE for his medialization thyroplasties. We have Radiesse, which is a combination of hydroxyapatite and carboxymethyl cellulose hydrogel for a shorter term implant. In rhinology, we have on the top left Maricel packs, and these are usually made with polyvinyl. We have nasal splints made of silicone. We have biodegradable stents like the Propel stent I've shown there. We use in after vesses. And then polyurethanes, which make up nasal pore. In otology, we have one of the most complicated or complex devices that we implant into the body, which is a cochlear implant. And these cells are seeing silicone, titanium, platinum. And then we also use otomimics, which is a hydroxyl apatite, which we use for canal reconstructions, sacral chain reconstructions. In facial plastics, silicone implants, like the chin implant I have shown here, there's a number of dermal fillers, both synthetic and natural, and both degradable and non-degradable. Hyaluronic acid, collagen, calcium hydroxyapatite, natural substances, polylactic acid, a degradable synthetic polymer, PMMA, which is a non-degradable synthetic polymer. So, unfortunately, there are few FDA-approved tissue engineer products in the market. There's not for a lack of extensive research, though. There's extensive research in skin substitutes, bone regeneration, cartilage reconstruction. I've listed some of the main products that are out there, skin being one of the most established areas. We have Alloderm, which is a decellularized donor skin, Epicel, which is a cultured autologous epidermis, Apligraph, bilayered construct with fibroblasts and collagen and keratinocytes overlying. We have Dermagraft, using allogeneic neonatal dermal fibroblasts cultured in a polymer mesh. Transite, using nylon mesh and with silicone on one side and human fibroblasts cultured on the other side. Then we have cartilage, autologous chondrocyte transplantation, as well as a biomaterial hydrogel with autologous chondrocytes. There are significant challenges in tissue engineering, which is why there are so few products out there. First is really the complexity in the 3D system that we're trying to build. There's always the discussion of 2D versus 3D. We have significant experience in 2D cultures and 2D experimentation, but it's been shown repeatedly that 2D experimentation does not always translate to the 3D system. And as you can see, we have a surface here, flat surface. Cells are only seeing one side of the surface and attaching in one area of the cell. In the 3D system, you have multiple attachments in different planes that the cells are seeing in the native environment. Another limitation is that of size. We still struggle to build vascularization into constructs and to support larger constructs. There's limitations in cell penetration. When we're seeding them, we build a scaffold of a certain size for an organ, for instance. Even if it's just a full solid organ with the same cell, you seed the cells around the scaffold, but they don't necessarily make it to the center. Then there's the lack of precise placement of the cells and the complexity of multicellular constructs. We have, our bodies are made of so many cells, and in such close proximity, it's hard to with the technology we have, to precisely place these cells in the locations they need to be and with the right interactions. So having said this, though, there's actually a relatively new technology that has been described, which I think has the potential of solving some of these limitations, and that is 3D printing. So the history of 3D printing is it's pretty recent. It was described in 1986 and credited to Charles Hall with a U.S. patent. He started a company. It started as a technique for prototyping in industry. It's a technique which is using additive manufacturing, which pretty much just means it builds in layers, and it can be in the micron and nanometer scales. There's little waste of materials as you're only building what you need, and there's a capability for customizability with the constructs that we make. I have a short video here it's hard to describe, but this video will hopefully kind of give you an idea of how this additive manufacturing works. And this is actually building or making cakes and food. Oh.
Peanut butter, even cakes.
All right, I'll play
Already, students at his lab have printed chocolate, peanut butter, even cakes.
So you can see with a design, with computer-assisted design softwares, you can get pretty precise constructs. So 3D printing has a number of applications we can use in otolaryngology in general. There's education. You can build models of really anything you really want for teaching medical students, residents, and also for patient instruction or patient communication. You can build models for simulation and preoperative planning. Dr. Devi already uses 3D printing for his mandibular reconstructions. He builds uses the CT scans of the mandibles and able to preoperatively plan what the deficit is going to be and pre-bend basically the bar. There's intraoperative surgical aids. Dr. Chang and Dr. Chong are already using 3D printing for this purpose. They're using 3D printing, a CT scan and 3D printing to build an exact replica of the ear that they're trying to reconstruct, and then using that as a guide intraoperatively when they're carving their cartilage. And then final application is implantable constructs, and I'll give some more examples later. So the 3D printing process, there's a number of steps. It starts off with having an image of the 3D construct that you're trying to design. This in clinically is usually with CTs and MRIs, and more so people are working on photography, being able to build constructs from a photograph, 3D photograph. And then picking a biomaterial, depending on the application, there's a number of biomaterials that can be used, synthetic and natural. You have to pick the cells. The type of cells can be a stem cell or a differentiated cell. It can be autologous, it can be allogeneic. And then you figure out the technique you want to use for bioprinting. And there's 3 currently described in their inkjet, microextrusion, and laser assisted. I'll describe this in a bit. Once you have this construct printed, it can be used for implantation, or if you have cells that need to mature, you can put them in bioreactors prior to implantation. They can be used for in vitro testing. So the 3D bioprinting approach, I have a schematic for the 3 different techniques. The inkjet bioprinter is probably the oldest and the most commonly used. It uses thermal energy or piezoelectric energy to push basically push droplets out of the nozzle. Microextrusion bioprinters use pneumatic or mechanical techniques to push out the solution. And out of the nozzle will come a continuous stream of the material or cell. Laser-assisted bioprinters, you have an energy absorbing layer as well as the biomaterial or cell layer. And laser pulses, precise laser pulses, will cause a bubble that drops the fluid or cells onto the surface. Each one has its advantages and disadvantages. Like I said, the inkjet printer is the most common and the first described. And some of the advantages are that it's fast. It's the fastest. It has high cell viability, greater than 85%, and printer cost is extremely low relative to other 2. and we have a micro extrusion. In this, the advantages here are really that you can deliver high density of cells. The disadvantages are it's slow. The viability can be low because of the shear forces as it's coming out, and the printer cost is a little more than the inkjet. Laser-assisted technique is high cell viability, and there's no nozzles, so there's no cell clogging situation that can occur with like with the other two that have nozzles. So the biomaterial properties that we need to consider when we're using 3D printing is really printability of the material. It's got to be able to go through one of these systems. Unless we come up with new systems, they have to be able to go through nozzles or be able to be delivered in the way that I mentioned. There's always the issue of biocompatibility and biomimicry. The structural and mechanical properties that you need in the construct, the degradation of the product, whether you want it to be able to degrade, and if so, degrading at the right time to produce the tissue that you want. And also byproducts from the materials that you use. Some of the materials, when they degrade, can change the pH, which can be toxic to cells. So two branches of biomaterials are being used at this time, and one of them is usually a structural support biomaterial, and these are a lot more rigid. They don't degrade as fast, like polycaprolactone. And then the other one is a cell support biomaterial, and these are usually hydrogels that are able to hold your cells in suspension. So common 3D printing materials, similar to those that I already described in general, are synthetic and natural biomaterials. And polycaprolactone is one of the most commonly used polymers for structure. But there are a number of materials that we can use to make hydrogels. Polyethylene glycol is a synthetic polymer that cross-links and forms the hydrogel through UV photopolymerization. And this can happen in minutes. Natural materials like collagen, hyaluronic acid, alginate, gelatin, fibrin, they all make hydrogels, and there's different ways of making them. Hydrophobic bonding, changing pH, UV photopolymerization, ion exchange, and these, depending on which you choose and your purpose, they are cross-linked in from seconds to hours. So then what have we been able to do with this new technology? I mean, this is a pretty new technology since 1980s, and there's already many applications, and I'm going to describe three that have been used in otolaryngology. And one of them is a non-cellular construct, an implantable airway splint. And the other is our cellular constructs. One of them is a skin substitute, and the other one is for cartilage regeneration or in auricular reconstruction. So the implantable airway splint, this was a case report from 2013 in the New England Journal of Medicine. Zopp et al. In Michigan, they had a patient an infant who was in respiratory, or who developed respiratory distress, chest wall retractions. The infant was found to have severe compression of the left mainstem bronchus from ascending and descending aortas. You can see in the CT here the area of compression and a kind of a 3D reconstruction of this. So they came up with the idea of making a polymer splint that they can put on the outside, that would hold the bronchus open and also allow for growth as the patient grows. So here we have, the 3D printed trachea with the area of compression, and then the material that they designed here. And then this is without, and then with the stent in place. And intraoperatively, this is a picture where they show where they place the splint. Sutures were placed almost circumferentially to hold the walls of the trachea out. And bronchoscopy here shows a patent airway in that segment. A year later, they have a CT here showing, there is patency in this mainstem bronchus. So this example here shows, custom patient-tailored design. It also shows simulation in preoperative planning. The next example is 3D printed skin. There's been other efforts made. Like I showed you before, there's already products out there, but this shows how 3D printing can produce a precise product. The Lee in 2014, they used collagen gel, fibroblasts, and keratinocytes to illustrate this. In the schematic here, shows the layering technique of their construct. Basically, collagen and fibroblasts were alternated to form the dermis, and then keratinocytes were placed overlying them. This is a photograph of the skin they're creating at day 0 and day 7, and then this is a immunofluorescent staining for tight junctions that are in native epidermis. So this is an example that can show the technique to give you precision and reproducibility. So the final example I wanted to show is in auricular reconstruction, and specifically cartilage regeneration. So in situation like microtia, the gold standard, what everybody's doing is still primarily harvesting rib cartilage and meticulously carving the cartilage to be symmetric to the other normal side. Well, in 3D printing here has the potential to provide a precise, customizable graft or construct. I have 2 videos here that I think show it better than me just describing it. And this one is from Dr. Benasser, Cornell University.
The real power of the printing technique is that it can be used to make geometries that you just can't make with any other technique. You can make parts with holes in them. We can layer and cover and put different cells next to each other to create really the complex organs that make up our bodies. And after 2 months in an incubator, the tissue fills in and looks white, just like real cartilage. The implants that we're making are not rubber or plastic. They are alive. They grow inside the body or out. And this has a whole host of advantages over conventional technology. The body accepts these materials like it's part of the body because it is.
I just said it was Holzinger's brother.
So his technique is really using soft polymers, as I described. It's most likely a hydrogel with cells layered in the precise locations that he wants to build the structure of the ear. And then we have Dr. Atala. This one, he's not talking. It's a report about him and 3D printing. And this is a really short video just to show kind of a different approach using 3D printing.
What you're watching is an ear being printed. Layer upon layer, tiny droplets are deposited, building up the structure.
So he's, if you're looking at this, and he's using one of the rigid polymers to build a scaffold for the year, and then he doesn't show it here, but there's two different methods you can use for seeding the cells. You can seed the cells at the same time you're building this year, which he has mentioned in another part of the video. You can also have the scaffold and then be able to apply the cell suspension into a incubator, or on top of the scaffold into the incubator. So, I think we've made significant progress in applying biomaterials in clinical problems, but there's still a lot to learn. 3D printing for tissue engineering holds tremendous potential, but there's still also a lot of research that needs to be done before we can print tissues that are even more complex with multiple cells and bigger structures. One of the main things we still need to develop is new biomaterials. There's a lot of common materials that people have been using, and some of it is the materials are good, they do the job. But I think part of the reason is also that some of these materials are already FDA approved, so it's easier to use a material that's already FDA approved to build a construct. But we need to understand more the cell-material interactions to design new biomaterials. We need to be able to manipulate and improve these cell-material interactions. And one of the ways that can be done, and people are looking into this, is using material scaffold libraries, like a sort of like a array of different scaffolds where you can seed cells and see the different responses. Cell sources, we still need to work on those. We need reproducible, we need abundant supplies of these cells to build the constructs, and then we need to understand and the cells and be able to manipulate them better. And this is mostly in the stem cell area. In terms of the bioprinter technology, I mean, it's pretty fantastic what we can already do, but to build more complex and complex tissues, we need more speed, we need even better resolution than we already have. In terms of construct design, again, I go back to vascularization. There's a lot of research being done, but there's still no good way of building a construct with arteries, veins, and capillaries in there. And then finally, it's innervation, building a construct that you can put in, you can be able to innovate either in terms of sensory or in terms of function. So, thank you.
What steps are being taken in terms of vascularization of the scaffold?
Yeah, so there's people. I mean, there's people trying to make conduits for before you even build the tissues around them, and then these would be seeded with the arterial system or venous endothelial cells, and then the materials would degrade out when the material is being built. Basically, that's one of the techniques that people are looking at.
The viability of the cells on any of those methods, is there any report, what cells are damaged or less viable? How that works usually with the three methods? You showed the laser, the inkjet, or so. Just
yeah, so I showed a table that describes
exactly
sort of these different systems and which one gives you the best cell viability. And it's the laser assisted printer, because there's no shearing forces. It doesn't go through a nozzle. It just kind of drops down. Whereas the micro extrusion, you have something that's pushing down on the solution going through a nozzle. So
interesting.
Has anybody been able to print functioning ciliated tissue, like sinus mucosa?
I have not seen that. I know people are working on mucosa, but I don't think that's there yet. But I don't have that information.
At these, last year at the first Congress of the International Society for Construction, I saw around 6 or 7 people give presentations on using 3D printers to make the cartilage frameworks. And the common thing that all of them said, though, was that these printed frameworks look beautiful, better than what you can actually even carve. But the problem is they don't have strong evidence that it will last over time.
That's true.
And it's times when they've tried to put it in animal models, it looks good for like a week, but then over time it loses all of its structure and kind of melts away.
Yeah, that is.
That could be a big problem.
Yes. Yeah. I think it was like in the 1997, Dr. Langer and Vicanti made that, the ear on the mouse, but they use like scaffolding outside to keep that framework. So that is definitely one area that needs to be addressed.
Tony Ritchie, looking ahead at inner ear regeneration, realizes that you can proliferate hair cells in the architecture of the cochlea, which is mostly there, but it doesn't give you polarity, it doesn't give you the orderly transition of the hair cells in the right place in the right way. And his thought is to create sort of a lizard ear, just a little slightly curved lagina, a little linear ear, done perhaps this way, and to bring that sensory membrane, if you will, on top of the organ of Corti, already in correct polarity and location of the right cells. Obviously, that's many years away.
Yes.
But the concept involved seems sound. And that way, the kind of cochleostomy that Jennifer Aliano's been working on, the ability to actually go into an ear without killing it, to place cells, not just happenstance. That's a big issue. I mean, you can proliferate hair cells, which will form all over the place, but it doesn't give you a functional organ of Corti. Have you thought about this for education? People are printing ossicles, I know, and temporal bones.
Yep.
And it's getting cheaper and better
Yeah.
all the time to do. It does, you wonder if you could do rehearsal simulations in that way.
Yeah, I mentioned that some of the applications is in building models for practice or for teaching patients, showing them their anatomy and what you're going to do. You can plan just like the airway splint example. Plan basically the size of the splint that you need for the situation. So.
Have you done that, Dr. Jackler? Have you drilled a 3D printed temporal bone?
Well, of course, there's a virtual one that Nick and Ohio State and others doesn't actually exist. We actually, Ashkan Monford produced a simulated middle ear, which was printed with all 3 ossicles, and you could do a stapedectomy in it. And it was a pretty good, given the fact that in many parts of the world it's hard to get genuine anatomic material, I think this is going to come.
Yeah.
I mean, that was rather costly because to create the die for the printer in, I think it was in Spain that actually did the printing. For those of you who might have worked with Ashkan a few years ago. Yeah, but I think it's going to get enormously less expensive than it's been to do.
Yeah.
And to find, I eventually went to sort of try to make multiple materials where there was an elastic joint between the incus and the stapes, for example, and so more rigid material and then play down the layer. So, I mean, these things are clearly coming.
Yeah. Well, I just was curious because one of my old chiefs who also at UCLA, which as you know, University of Cash for Legs and Arms, we did not have a donor program because people were selling body parts, so we didn't see temporal bones during my entire residency. We drilled on human beings, and that's it. We didn't have a temporal bone lab. So she actually has done 3D printing down in Georgia, and she has showed a video of her drilling a temporal bone from a patient's CT scan, a very cheap temporal bone that would be, she said, very easy for especially the beginnings of early residency, and very helpful. So it was amazing that it was fast and cheap. I didn't know if you'd heard anything about it or.
Nick may have. I don't know if any of our colleagues have, but it's interesting. For those of you who don't know, one of the deaners at UCLA was selling arms and legs from donated patients for substantial money to orthopedic supply houses and things. Yeah, it did not go well. Made the front page of the LA Times for quite a few days. Yes, it's probably the best run and safest cadaver lab around now.
Yeah.
Just as an interjection, so we can 3D print any virtual model that we drill on our simulation software.
Yeah.
The problem is printing that in materials that are actually
Right.
fidelity, that have a fidelity of real temple.
Yeah.
That's our argument.
Materials,
Yeah.
so the cost of the capital equipment to do that is expensive.
Yeah.
3D printing with those materials
Sure.
is not that expensive.
Yeah, she said the anatomies there, things just kind of flake away on the drill though. And those is,
Right, but it's very useful. We printed a few things for Dr. Devi a few days ago, jaws. And
Yeah.
whatever we can-
Yeah, I mean,
Vasu purchased a 3D printer, right, out of the VA.
the
Oh, did he?
Yeah.
But if any of you guys are interested in
I
having
meant
3D
government,
printed
yeah.
models for patient education, for resident education, we're happy to do it for you. No problem.
Right, just pay for the consumables, right?
It's nothing really.
it's,
Really?
The
they're super
materials are
cheap.
very inexpensive,
Oh.
and we can print, just for example, half of a mandible and an eye.
if you guys want 3D printers, that you can buy them for just a couple of grand nowadays. Off the internet, you can just Google it and you can buy 3D printers.